sir. I hope you are doing well. Speakers, participants, let me introduce you to our next speaker, that is Dr. Sagarmoy Ghosh, a distinguished professor in the Department of Microbiology, University of Calcutta. Dr. Ghosh has been with the University of Calcutta since 2003. His research interests lie primarily in the field of bacteria. He has a significant publication record demonstrating his dedication to advancing knowledge in microbiology. Today, Dr. Ghosh will be sharing his expertise on the crucial topic of public health post-pandemic preparedness. In a world that has recently faced the challenges of a global pandemic, understanding and preparing for future public health crises is more important than ever. Dr. Ghosh's insight will undoubtedly provide valuable perspectives on this critical issue. Over to you, sir.
Thank you very much for the nice introduction and a very good afternoon to everyone. I hope the slides are all visible and I'm audible perfectly.
Yes, sir.
Okay. So, so today, what I have decided, depending on how the world is moving nowadays and how the perspectives have changed so drastically over the last 5 years, starting from 2020, after the COVID pandemic. So initially, that hunky-dory world of everything is going well in terms of how we are keeping pace with the scientific development, how we are keeping pace with our health scenario and everything. That really received a big jolt when the COVID hit us, and that really put into perspective what exactly is happening in the public health front. So are we paying enough attention to the sectors which actually require our our strong interference, or are were we just pampering to a trend which does not really benefit us much when the situation demands the most. So based on these things, there are certain thoughts that I would like to share with you. And in terms of what or where the current public health scenario is heading towards, I would try to make a guess. And of course, it's a guess. I'm not going to say that is what is going to happen. But definitely, there are certain questions that emerge during those 2 years, 2020 and 2021, which really makes us wonder where exactly we are heading in terms of our public health infrastructure and public health research. Now, to begin our discussion, we are trying to concentrate on Indian scenario here, and most of the data that I'll be presenting here is government data, our national health policy data, the different white papers, different government announcements that has come over the last 2 or 3 years on different disease sectors. I've tried to compile this talk based on those only. And as per government data, so before the pandemic hit us, so in the period say 3 years, 2016 to 2018, the major causes of death in India was cardiovascular diseases and say uh, the malignancies. So individually, those two could be those two are contributing mostly to the diseases which were happening, and of course there were respiratory diseases. So these three components over here, cardiovascular disease, respiratory disease, and malignancies and other things, those were the known causes of deaths, accounting to about say 40% or 42% of in total deaths happening. Rest of all the diseases combined made up about say 58%, and its individual share were always less than these three combined or these three individually. So these are the viruses like more than half of the deaths like the behavioral diseases as well as the pathogen induced diseases as well as like say vehicle accidents etc unintentional injuries and the perinatal conditions, those were all contributing to these factors. So essentially the focus of healthcare research and the development of public health infrastructure was mainly focused on these cardiovascular diseases, respiratory diseases, and malignancies and other neoplasias. Obviously, what happened after the pandemic, we suddenly realized that the healthcare infrastructure, and here I'm talking about both private and the public sector, were actually found to be remarkably short of what we are kind of expected. We have kind of expected from the system to be able to stand by us when the situation were demanding. Granted that, like the 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 way the COVID pandemic, the tsunami of information uh, uh, and the danger that hit us immediately after the disease was kind of discovered in India. So we realized, like we had to do something, and we had to change the way we are looking at things till then. Now, in India, these
Sir, Sagarmoy sir, you are not audible. Sir, can you hear me? Okay, there are some technical issues. Please wait for a while.
Am I audible now?
Yes, sir, you're audible.
Sir, now we can see you.
Ah, okay. Okay now?
Yes, sir.
Yes, sir.
Okay. So what I was talking about is like the vector-borne diseases, malaria, dengue, and chikungunya. They make up about say more than 95% of all vector-borne diseases. Now, one argument can be put forward, like this burden of vector-borne diseases could be actually reduced to even a lower value, lot lower value, if we take good care of our infrastructure, of our public hygiene, etc., etc. Which is true because if you somehow can prevent the growth of these vectors, then we actually prevent the ability of these diseases to spread into the population. Now, in case of say malaria, I mean there's a long-standing program, government program with the WHO assistance and United Nations assistance. But according to World Malaria Report by WHO in 2023, WHO claims that about 66% in Southeast Asia were occurring in India. However, this number was not actually in agreement with the government values, which says about say 8.88% of the extreme burden in Southeast Asia is happening in India. Nevertheless, like I'm not going into the nitty-gritties of which number to trust or not, but still, this about say 9% of the estimated Southeast Asian malaria cases happening in India can be reduced even further if the good healthcare practices, good hygienic practices are maintained in the society. Another important issue that we must pay our attention to is that of the financial and the societal status of individuals in India. I mean, I'm not saying that only the poor actually gets infected by the mycobacterium tuberculosis. It also happens in the high income groups as well. But the fact remains that these diseases have actually been very hard to remove from the population in India, despite government expenditure to the tunes of several hundreds of crores after these diseases. Which we can actually pull down the dependence of the society, or which burdens the public healthcare system, is the issue of the drinking water source and the location of drinking water sources within the population. Like only 32% of the drinking water that is consumed in India are from treated sources. About 54% of the population have to bring the water from the sources which is away from their homes. The reason these two information are important is that unless we can provide treated drinking water to the majority, or at least 80% of the population, the public healthcare burden will always going to remain high because people are going to be infected with it anyway. Secondly, if the drinking water is not provided within the premises itself, it is almost impossible for the women folk to actually gather water every day, drink water every day for the entire household, and which is going to get into some compromises and that compromises will have their bearing in the healthcare system. So the point I'm trying to make here is that the public healthcare burden is not only dependent on how much government spends on the public healthcare itself. The, the, the more you stretch the system, because you are not providing development in other factors, other sectors in pace with the growth of the public healthcare system, your public healthcare system is going to find some strain which will be which will be quite frustrating in the situation when demands it the most. Now, if you look at the different communicable diseases that is happening in the population in say 2021 itself, you will find that respiratory infection deaths close to say 10,000. Okay, this is government data. I mean, I'm not going to debate anything on that. And the diarrheal diseases are about say 1400, enteric fever 229, pneumonia 14,000, and viral hepatitis say 300. So, so pneumonia and acute respiratory infection, they actually cover about say 25,000, which is close to say 80% to 90% of the total communicable disease deaths, like reported in the government registry. Meaning that the air quality as well as the individual hygiene or the individual immune status of the individuals, of ordinary human individuals, is actually the respiratory tract infections and pneumonia related infections. They make up most of this scenario. So unless our government healthcare system is actually geared to handle these respiratory infections properly, because that is where the communicable disease deaths are happening mostly. So when we devise our strategy how to strengthen the healthcare system, we must keep an eye on these data as well, where we should be able to tell which particular departments, which particular area in the public healthcare system should be augmented first as opposed to the other. Now, during this COVID-19 pandemic, several things have come to the fore internationally. I'm not really talking about India in particular here. And on top of that, first of all, is a lack of knowledgeable leadership. And by knowledgeable, by leadership, I'm not only talking about the political leadership. I'm also talking about the scientific leadership, which is very unfortunate though. Like with the number of graduates and PhDs that come out of our Indian education system in such huge numbers every year, come pandemic, we have all witnessed that very few knowledgeable inputs were made from the scientific or the teaching community about how we should handle the COVID-19 pandemic. We were, in spite of their training, in spite of the work that we do, we put ourselves the same backseat as the general population, and we always expected our masters to tell us what to do. We have failed miserably, the teaching and the research community. I'm sorry to say, we have failed miserably in giving any direction to the population or the government during the pandemic, and which that definitely needs to change. Secondly, the one thing that was grossly uh, laid bare was the infrastructural inadequacies. Suddenly, we found our hospitals are not ready. Suddenly, we found our doctors and the nurses were not really in good numbers to handle such a huge influx of patients. The hospitals did not have enough beds. The hospitals did not have enough ventilators. Hospitals did not have enough sterile equipment. So the list will go on, but everything that we came to face during those 6 or 8 months or even a year were horrible to say the least. Thirdly, we needed a strategy come on to reorient available resources. It took about say 4 months for the government to take hold of the situation and channelize resources as the need arose. So we need to be prepared beforehand. So if a respiratory disease related situation arises, what are the things that will be required? What are the things that can be immediately put into discussion? So that sort of understanding thought can always argue like we never had a situation like that before, so that's the reason why we took so much time to prepare ourselves. Nevertheless, we need to have such ideas coming once we have it now. So in the coming days, when we do not know what the next disease will emerge from or what type of disease that might be. So we need to have such thoughts put in place well in advance so that we do not really lose another 4 months time while deciding at the same time when our population is dying. So we have to be careful on that point as well. Last 2 points basically involves us. That is need to curtail spread of misinformation. We have all experienced the different type of stories that the interaction during those pandemic period. Most of it was nonsense. Most of it was coming from utter ignorance of how the disease works or how the healthcare system works. But people would immediately believe, what was being said in national television or private channels or in the biggest university of all time, the WhatsApp. So we were believing, this is happening, this is happening. Once we receive this misinformation, I forward it to 20 other people. They forward it to another 20 people individually. So in no time at all, this information spreads like wildfire. So we need to apply our mind. I mean, at least the educated people should apply their mind and say, well, this is the misinformation. Please don't spread it. We should stop. Otherwise, we are those who do not really know a single thing about it. They are very, very gullible. They can be easily convinced of such misinformation. So, how do you do that? That is, you have to increase public awareness. The public awareness of the disease, public awareness what should be done, public awareness of how hygiene could be maintained, public awareness of how the healthcare system should be approached for the treatment of a disease. So I mean, you find like every now and then, when a patient gets admitted into a hospital and he or she dies, then we go and ransack the hospital. I mean, without taking into account what was being done. I mean, we should not expect. I mean, no system will guarantee that every individual who is suffering from a disease, he or she gets into the hospital, he or she will get cured. So if that was the case, nobody would have died. So I mean that's not real. So but at the same time, we should also be careful about we get the proper treatment from the hospital as well. So we have to be rational to what to expect from the system, and we expect the system to perform. We expect the system to deliver, and when unless that happens, the public will not have in the public health infrastructure. Once we don't have it, then that's a big case of concern. I mean, not. I mean, I'm not really very kind of insinuating anything. Suppose we have a general perception, general perception that public healthcare system in West Bengal is probably not as good as as it should be, and that's the reason why we always go to other states for treatment. Okay, but is it always is it always true? I mean, if you go to a public hospital over here, so many people are coming, and they all dying. And but at the same time, you open up your television channel, you find all kinds of gory news coming about things going in the government hospital. So whom do you trust? So what do you do when something happens in your own family? So that way, there's a there's a gap in having the trust in the system. Once the government or the public they lose trust in the system, then it gives rise to the complications which as an individual you will have to suffer. The government is not going to suffer for you. So that way, the awareness of what is right and what is wrong, at least in the educated community, is very important to make the system work, to make the public health system go forward. Now, when we talk about this public awareness, public health awareness, and how people should actually see the public health care system. So let's see, where do we stand, India stand, in terms of say healthcare expenditure versus GDP per capita. Okay, so if you can see my cursor moving, we stand somewhere here. Okay, what is it? Somewhere here. India is somewhere here. Okay, and most of the developed countries, they are spending more on healthcare GDP per capita than us. Okay, there are little small exceptions, like say Turkey, for example. Okay, Turkey is not really considered a very rich country. Okay, very well developed country for that matter. At least not in the same league as a other NATO countries or other countries in Europe. Turkey still spends a lot more than we do. What's about say Indonesia? It's not a very rich country, but they're still like spending more. Nicaragua spending more, but we are like here in the bottom quarter percentile of the of different countries who are spending. That is not expected. We the government needs to spend more so that the huge 150 crores population that we have now, we need to have more infrastructure. I mean, why do people from the remote villages will always have to come to say SSK hospital for treatment? What are the are the primary secondary infrastructure in the state? What is that doing? The reason that is happening, all the government hospitals in Kolkata, the capital, state capital, is overburdened because the other hospitals in the district or in the block level, okay, or the division level, they are not working properly. So unless you develop that infrastructure better, you cannot really have your super specialty hospitals treating the general cases. You have to have some such division of cases, what sort of cases are dealt with in which sort of hospitals. You cannot really take every single disease to the best hospital that you have. You have to have a pyramidal system in which you get 99% of the diseases taken care of within say 10 or 20 kilometer radius of your house. Only in case of say or difficult ones, you should be moving out of your home and go somewhere else. But here the case is just the opposite. For 100% of the cases, you will have to move in excess of 100 kilometers to get the health care, and that doesn't sound well for a such a hyped country for like India. But for a simple disease, you will have to travel about 100 kilometers to get the disease treated. So the government healthcare expenditure in terms of percent of GDP is rising. So we should not always blame the government. My whole point is how is this money being spent and where this money is going. Okay, so government has increased its share of health expenditure in terms of GDP from 1.9% in 2018 to say about say 2.3% now, and that they plan to make it to 2.5% of GDP by 2025 by this year, which is like a step in the right direction. But is it adequate? And again, the second part of the question, where it is being spent. So the government says this last year it said that healthcare has become more affordable. I know we will all disagree with this, and I'll tell you why we disagree and what is government saying and why are we feeling the pinch. And it's accessible over the past few years. Now it says that primary healthcare expenditure, which is where most of the funding should be going, increased to 55.9% of government health expenditure. Absolutely nice thing to have. And as a result, infant mortality rate has declined to 28 per lakh, and maternal mortality rate has declined to 97 per lakh live births. Okay, so unless you are increasing, you are strengthening your primary healthcare expenditure, where say more than 90% of the diseases should be treated within a radius of say 10 kilometers from your house, that is the way to go. And government says that's where we are going. But the problem is, as we see, the health expenditure, health is a concurrent list subject. Means both the central government and the state government, they both spend on health to build the health infrastructure. And you will see in both the cases for 2 years, from 1819 and 1920, the state budget, its own expenditure, is about covers more than say 50%, so 70% in both the years. The central expenditure is about say 25%. So states are spending from their resources double of what the government has spent. Okay, and same is true over here as well. So in total, so the states are also spending, the center is also spending, but where is this money going? Okay. Now, as I said previously, the allocation of money that is being used to build the infrastructure should be monitored in a way so that we have a proportionate growth of different sectors. So if the state can actually spending that much amount of money, they should be asked to spend that in building up the primary infrastructure so that people don't have to primary healthcare infrastructure so that people don't have to travel a lot to get the treatment done. The onus is on the state to ensure that the citizens of their state does not really have to run from pillar to post to get the treatment. So it's a state's responsibility to build a primary healthcare infrastructure and the secondary at least up till the district level. Beyond that, when you go to a tertiary level, suppose you talk about the SSK hospital here, or say Safdarjung in Delhi, or like other big government hospitals, they should be super specialty hospitals, and they should get direct central funding so that all state of the art things can be done under one roof. And each and every state capital should have one such. It's not about talking about aims, we just made aims, etc. etc. I mean, teaching institution is a separate thing, healthcare institution is a separate thing. When you mix the two, then there is a problem. So if you are making enough number of doctors and nurses, you should not have a problem in getting the trained infrastructure in both the primary, secondary, and tertiary sector. But the central 25% expenditure on healthcare budget should be spent on making the tertiary infrastructure, and there should be one good government hospital in every state capital, which will not be flooded by the cases coming from the deep down from the primary healthcare infrastructure all the way up to the tertiary infrastructure, so that the tertiary infrastructure is not overburdened and can be used for looking into the difficult ones. But the zonal, divisional, and the district ones, as well as the primary healthcare facilities, they need to be strengthened so that people don't really have to go a long distance to get the treatment. Now, the reason we are saying the healthcare system, the amount that the government is spending, might seem inadequate in the long run, is because how the age structure population pyramid looks like for India nowadays. Probably you have heard oftentimes that India is a good job market because we have lots of individuals which are below the age of 30. We have a very young population that we have right now, and this young population is actually a boon for any industry, and as because for the educated or the skilled manpower of this huge population can be employed in any field. Now, problem is, so if this is the age group distribution in 2011, by say 2036, these young people will grow old, and the percentage of the young population below the age of 30 will be skewed now towards below the age of 50. So as you progress in age, you actually accumulate diseases. So these individuals, which did not come to the hospital because they were young and they didn't really have that much amount of say different diseases happening to them, will now overpopulate your structure in next 10 or 15 years. Question is, after the pandemic, are we paying enough attention to the fact that as this young population grows old, when they will be in need of say regular healthcare, are we in a position to provide them that? I think the answer is pretty much like clear to everyone that we are not. Why are we not? The simple reason, as I stated before, we have not made a stratified healthcare system. We have not made like the infrastructure available to everyone from a remote village to a town where you get the primary healthcare available, primary, I mean, and adequate healthcare available to everyone within say 5 or 10 kilometers from where you reside. What is happening? So these people in the villages will grow old, will turn 50. They'll require healthcare, and the number will be 5 or 10 fold than what you see today in say PG hospital. In 10 years' time, that number will be 10 times more. Do you think our PG hospital will be able to cater to that? Absolutely not. So the way out is the primary and secondary tertiary, I mean, district level infrastructure, they need to be bolstered. Secondly, as you can already see in 2020, several of the states, say Kerala, Tamil Nadu, West Bengal, okay, Jammu and Kashmir, their 60 plus age group population is already more than 10%. Okay? And these people are in immediate need of any healthcare support mostly. This number is going to go to about say 20 to 25% or even 30% by say next 10 years. What are we going to do with them? We have no idea. So are we prepared enough? Are we have a policy for looking into them? I don't know. And it doesn't seem like that they do. Secondly, the population growth pattern in India is actually decreasing. It's a good thing. I mean, from say 12% in 2010, it has probably come down to about say uh, in these next 5 years, it will be close to say 7%, and it will eventually come down to below 6% in say 2030 to 35. So it's a good thing. Like the numbers will be decreasing. Bad thing at the same time, because your childbirth ratio is coming down, your geriatric population, your old age population, percentage wise, it will grow up, straining our healthcare system even more. So next up, so how much are we actually spending? How much are we actually ready to spend? Okay, because there will be people who will be going to private healthcare system, while most of the people will be going to the government healthcare system. So if you see for the last 10 years how per capita national income has changed, since 2011 it was about say at constant prices. Okay, so I mean this is an economic term that says like you actually have a ceiling, and whatever the inflation is you correct for that. So how much are we uh, earning in terms of say in terms of say last 10 years? So in 2011, suppose we were earning say 63,000, and 2021-22 that earning has gone up to say 93%. So about say 50% increase in our earning per capita nationally in the last decade. Okay, now as this per capita national income has increased, so has the price of the healthcare cost has gone up, and this out of pocket expenditure for treatment, government is claiming is actually coming down. So this government says that the out of pocket expenditure, like so you have to pay for the services for the medicines, etc., from say 64% to 48%. Meaning that whatever that your medical cost is, if you are hospitalized or if you're like undergoing OPD care, about say 50% of the cost now you will have to bear. Okay. In case of say share expenditure, share of expenditure in the health, in the total expenditure of social services, healthcare has actually increased from 21% in so government in the healthcare sector. So schools, nursing, maybe be schools, nursing schools, central state government budgeted expenditure in health sector touches 2.1% of GDP against 1.6%. কিছু বলছেন আমি বুঝতে পারিনি। হ্যালো, কিছু বলছেন কেউ?
না স্যার, বোধহয় একটু আনমিউট হয়ে গেছিল। Sir, please continue.
Should I continue?
Sir, sir, please continue, sir. One of the participants has unmuted, so that's why some voice is coming, sir. Now it's okay. You can continue.
Okay. So the point was, like, government is spending in, and the cost has come down. Where is the problem? I'll go into the next slide. Now you see, like, every time, like, the insurance sector is getting opened up, so international insurance companies will come. So what is going to change, and how does it affect us? See, if you can see here, the penetration, insurance penetration, that is percentage of people who are insured in some way, be it health insurance, life insurance, it's anything. The global average is about, say, 7%. Okay? The Indian average is 3.7%. So it's about half. So is it good or bad? Essentially, we have always taken insurance as investment, which is not right. Because if you are in a position to invest, then you should invest. You should get returns from it. Okay. Insurance is, on the other hand, is a protection against eventualities, and that eventuality, if it comes, then only you get paid. So suppose you are paying a LIC premium, say 20,000, okay, per year. I mean, I'm talking of a small sum. So, and this 20,000 is probably, you have bought the life insurance for say 5 years. So you will be paying, say, 20,000. I mean, say, for say 10 years. So you are paying 20,000 per year. So you will be paying, say, 2 lakhs in 10 years. So when it matures, you will probably get 2 lakhs back. Okay. But by the time the inflation has gone up, so this 2 lakh is probably has come down to 1 lakh, 1,20,000, something like that. So as a matter of fact, in say 10 years, you have lost the value of money. But if you had debt within these 10 years, then you have gotten those 2 lakhs and your family would have benefited from it. Okay. But if you had invested this 20,000 every year in say different stocks, in like in other market related products, this 20,000 would have given you every year. So you have 2 lakhs. You probably would have gotten, by that time, in those 20 years, you have probably have gotten 6 or 7 lakhs. So people factor in those ratios and say, like, by paying insurance, we'll rather pay in investment, and then if something happens, we'll break that investment and get the health care. What happens here, as because you have not bought any kind of insurance, so the insurance companies, when they charge premium at you, they actually make good of the people who have not bought the insurance policies, because they do not know how much costly the insurance is going to be like, or the procedure is going to be like. So they are making an upfront payment or upfront infrastructural commitment, and as because they don't really have many numbers to support that commitment, so they are going to increase the premium only. Now the density, why the second column, the insurance density talks about the how much, how fat you are, how thick you are in terms of the insurance that you have bought. And there you see, India is probably about, say, 10% in terms of thickness of insurance than the rest of the world. So if the rest of the world per capita insurance value is say $900. In India is barely say $100. So even if like when we buy insurance, we buy cheap insurance, and so it doesn't really cover much because to start with most people are not buying insurance, and secondly those who are buying it, they are buying for a nominal sum. So essentially what is happening, that the insurance companies, they don't see profit in doing the business over here, but to exist in the market, they increase your insurance premium. The moment you spend more on your insurance premium, your expectation is high, but the service that you get for that high premium is low. You see my point? So it's kind of nobody gains from this scenario. So what is the way out? The way out is you need to have comparatively cheaper insurance that buys you more coverage. So in order for that to happen, you need to have more people under the insurance umbrella paying a decent amount of insurance, so that the insurance companies now have the cash to pay you, and they can support you for a higher amount. Unless that is happening, all in, we must have experienced it. The Mediclaim premium has shot up about say 100% in the last say 5 or 7 years. Why is that happening? The reason is simple. The healthcare cost has gone up, but the number of people opting for Mediclaim or health insurance, that has gone down. And when even though those people who are having it are actually buying it for less, because say 10 years back, to buy a 5 lakh Mediclaim, probably you will have to, depending on your age, probably you were shelling out about say 10 or 12,000. Now the same person of the same age, for a 5 lakh Mediclaim premium, will be paying about say 18,000. So as because the insurance market has not really grown up that big, you are actually paying more to get less. Now that's actually reflected in this slide. It shows over here, like the total claim in insurance is actually showing a negative trend. Okay, suppose say in 2020 2023, say 88.89% claims were settled. Okay, now it has come down. Okay, and for everything else, so the trend is for the group business, for the individual business, etc. For everywhere, the trend is actually coming down. Meaning the insurance companies are tightening their pockets, and they are not trying to settle your claims. But you have paid more to get less, and even that is being cutted. So why do you? So this is the problem that we are going to face unless we have a very serious look at our healthcare system. The healthcare system, if it is not kind of made in tears, that these diseases, the primary diseases, will have to be taken care by the primary healthcare system within a 10-kilometer radius of your residence. And unless they want you to go to the next stage, you cannot go to the next stage. So you cannot really decide, like where you want to go. You cannot really go to the tertiary hospital just because you have lost faith. But the government has to do everything to gain your faith, to earn, to win your faith in the system, or even by the healthcare providers. Even it could be private hospitals, it could be government hospitals, but you need to have this primary healthcare system going, where the tertiary system remains free to care for the where it deserves more attention, most attention. So, what is the take-home message? That even though the government spending has increased considerably, the individual payout is increasing because the coverage has come down for the same buck. So you are paying out more. Okay, so getting sick is going to be more expensive unless there is something drastically looked into. Second, in coming years, health insurance premium are expected to cost even more. I explained why. Rising cost of hospitalization and allied costs, along with low insurance penetration, will keep indoor treatment costly. I think I explained it adequately. Like where the insurance companies see they are losing, where customers feel they are losing. At the same time, you see multiple hospitals coming up, but you still complain because you are not getting the treatment because the treatment is not available at the right time at the right place. Communicable diseases remain an area of concern from both patient and insurer perspectives. Unless the public healthcare system, the general hygiene, etc., those things are improved, these communicable diseases, especially the respiratory ones, which uh, uh, you know, infects our respiratory tract, that is going to be a serious issue because we are not paying enough attention to the pollution level or different other factors. I mean, the industrial effluent treatment, etc., etc. So those things will remain a concern. Finally, that's where we, as the community of the teaching or the research community in India, should contribute, so to say, is the development of indigenous drugs and instruments. In most of the cases, the cost of treatment is because those instruments are not indigenous and they need to be imported. And the government, you know, charges are so the
Sir, you're not audible.
not charge
Sir, can you
that
hear
much
me?
as they are doing now. Yeah.
Sir, you were not audible. Now it is audible, sir. You can carry on.
Okay. So these are the things that we need to put our attention on in the coming days to make the system equitable to everyone, to government, the general public, the insurance community. So we need to focus. We need to focus and we need to understand where we should be putting our emphasis on. Just making large hospitals is not going to change anything unless we make sure that what we decide to treat in there. I mean, it's not your sign of success that you're in your hospital every day 10,000 patients come. That is not a index of success. That means we have failed somewhere else, and that is the reason why your hospital is getting thronged by so many people. You should have say 10 hospitals where 1,000 people come every day. You should not make one hospital where 10,000 people come every day. So you see my point. So that's the way I think we should look at the healthcare so that everyone gets into a win-win situation and people can afford treatment. I'm afraid the way things are going, probably 10 years down the line, we will not be in a position to afford the treatment even for the accessible diseases. I think that's it. And thank you. Thank you for your attention. And if there are any questions, I'll
Thank,
take it now.
thank you, sir, for your insightful talks and increasing our awareness. Do we have any questions from the participants?
Sir, I have a question.
Sure, please go ahead.
Sir, what I can see from your presentation that Sir, what I can see from your presentation that this annual cost of our this insurance is going to increase in coming days. So, sir, the
Mhm.
question is that we are also observing that our the population is continuously increasing, and
Mm.
can't we see the reverse that with the increase of population and the decrease of this annual cost of premium, So will it be possible? And if it is possible, then when can we see this kind of thing?
Yeah, that's what I'm saying. India remains in terms of say penetration, we are about say half of the world trade. Okay, so I mean
Right, sir.
most of the people here are uninsured. First, second, the depth of penetration, how much you pay your premium for how much. Say I actually buy say mediclaim premium mediclaim policy was say 5 lakhs. Okay, and we understand 5 lakhs is nothing now, and that 5 lakhs too is for my entire family. So even if I count as an insured individual, but the amount of money that I am paying for is not actually that much. So what happens if I get admitted? So obviously, even if I have the Mediclaim going on for say 20 years, as because that amount is low, so the moment probably 5 or 7 days goes by, then insurance say, well, we have exhausted all the protection that you had, so now you have to shell out from your pocket. So that way your out of pocket expenditure, even though I have paid premium for the last 20 years, is not going to save me from the blushes for if I get admitted. So the only way out is if more people are there in the premium, are there in the insurance bracket. So actually, the small ones, the insurance company has a large amount of money so that they can like you know they can now think of reducing the premium so that the more people get in, and the cost of treatment when it comes down because of the indigenous development of drugs and machines, that way only the healthcare cost can be put under one's control. Otherwise, the way things are going now, it's going to spiral out of our control, any control whatsoever in over the last decade, over the next decade. So if the 5 lakhs insurance coverage that you are paying for now is now will not be worth a peanut in say 2035, 40.
Right, sir. Got it, sir. Got it. Thank you so much, sir.
Uh,
সবাই কি
Good
ভয়
afternoon,
পাওয়াতে
sir.
পেরেছি কি ঠিকঠাক?
I have an observation
Yes,
to
sir. I
share.
think we have another question.
Sure.
Yeah, sir, I have an observation to share. Like in
Hmm.
West Bengal, whatever for example, if we have a respiratory distress or respiratory disease, we go to a medical practitioner and he gives a broad spectrum antibiotic, and that is how it's a broad spectrum antibiotic, then its organisms get killed and the person gets cured. But I found a stark difference in the way the treatment is done in South India. What they do is they do bronchiostomy, they do a profiling of the culture sensitivity of the microorganisms, and they treat it target specific. So what happens, the organism causative agent of the particular respiratory disease gets killed. So in what happens here is that broad spectrum antibiotic kills all the organisms. We don't know which organism it kills. Out of that, one resistant organisms comes into play and they survive. Evolution helps them to thrive, and that is how it becomes more difficult to treat as they continuously evolve. And when we tell the patients, I mean, I this is my observation, when the patients are told to go and done a bronchoscopy done for respiratory illness, they feel that the medical practitioners, they get a gut money or commission from the investigation centers. So to keep the patient's confidence and the healthcare system intact, doctors prescribe broad spectrum antibiotics, for which both are at risk: the practitioners, the healthcare providers, as well as the patients. And also
Absolutely.
there's one more threat in West Bengal is that we see the practicing quacks who have no medical knowledge, but over the years they have gained certain knowledge, and with that they start treatment. So this is my observation, and according to what you have delivered today, I could just share my observation. Thank you, sir.
No, sure, absolutely. I totally agree with you. That's what I said. I mean, our primary health care and the trust, these two factors I repeatedly mentioned over here. Unless you can build that trust, and you can only build that trust when you have a stratified system which delivers and which delivers right next to where you live. Unless that is happening, as you say, if a doctor asks for a scientific review of the disease and treatment, that doctor is is looked at with suspicion. At the same time, when you go to south, or when you go to or like in other places, you don't really have that trust factor. Like, when the doctor goes, when a doctor tells me to go for bronchoscopy, he or she is not asking for his or her commission. But here, the moment you do that, there's one kind of atmosphere. Like, as I said, I gave you the example of ransacking of hospitals. I mean, we don't have any knowledge of what was going on, what is happening, but my nearest kin dies, I have an automatic right of, like, demolishing whatever comes my way, and the system kind of allows that. I mean, system is not doing anything to earn the trust, and so there's a reason why they don't mind somebody, like, not giving back anything to it. So unless this sort of interest or this sort of thinking changes, so that way, like, we cannot really develop. I was speaking not nationally, not
So public
specifically for West
awareness,
Bengal.
more public awareness program is required. In fact, in rural belt, urban
Yeah,
belt, all
but
over.
but 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 just doing the programs don't help, because you need to see things in action. Unless that is there, how just having a program is going to help? I mean, if you do not really get the medicine or the doctors or the infrastructure in the primary healthcare center near you, just having a program, how is it going to help? So if you, like, if you have the habit, you can make a habit of going to a PHC, primary health center, and you get the right treatment over there. You have enough staffs, enough instruments. They don't have even have an extra machine. So if something, if someone breaks his bone, they have to refer it to the to a bigger hospital. Why can't the it's not? I mean, but the extra center will be running next to the primary PHC. So, the government cannot actually run one extra machine in such centers. People are telling. I mean, that's not right. I think that's the reason I say. I mean, you have to earn the trust of the public, and for that, the government has to, the state government specifically, will have to build the primary healthcare infrastructure. Tertiary healthcare infrastructure, it needs more money, more sophisticated instruments. Let the central government funds be get used for that. So the state government should concentrate more on building these secondary and primary networks.
Thank you, sir.
Thank you, sir, once again for your valuable time today. And this brings us to the end of the program. We shall again meet tomorrow as per schedule.
Okay. Thank you everyone. Thanks for your time.
Thank you, sir.
বেরিয়ে যাচ্ছি তাহলে।
This is the